Hi, a very good evening to all of you. So how are everyone doing today? So myself, I'm Dr. Jazeer Abdul Kader, your dermatology faculty at Physics Wallah Medit. So today we are planning to have a very quick discussion about the previous year questions for NEET PG. And along with this discussion, whatever doubts you may have regarding the subject, I'll be happy to assist you. So I hope that, hi Osama, I hope that you're doing good. Yeah, just a minute. Yes. So that is about today's session. So it is a live session that is going on. And what we have done is we have collected some of the MCQs that has come from dermatology over the past several years. And these questions will be discussed. And as and when I discuss these MCQs, I'll also try to go a little bit deep into the topic because usually all of you know that the topics are usually repeated, not the same questions, and we'll try to identify what are the most important topics that you should be preparing for your NEET PG so that you don't miss on any of those important topics. And as you know that dermatology, what is expected? It is always expected that you may get a lot of image-based questions, right? So some image-based questions, some clinical-based scenarios, all these things shall be discussed today. Without wasting much time, now let's begin the session with the first question. Now, now let's see the first question. This question says that there is a 10-year-old male child who complains of a mild painful swelling over the scalp for 3 months as shown in the image below. He also has a pet dog at his home. What is the diagnosis of the given condition? Now once you examine the image that is given in this MCQ, you can see that there is a kind of a patchy hair loss as well. Correct? Now the options given are furuncle, epidermoid cyst, chorion, and folliculitis. Now, what do you think? Now, here, what are the main pointers in this MCQ? The first one is an age, which shows that this probably is something that has something to do with children. It is, or else, let us say, which is more common in children. And this child is complaining of pain. Pain is not a usual symptom in dermatology, but here there is a painful swelling of the scalp. Now this is present for 3 months, and over this 3 months, what has happened? Uh, what has happened is there is a patchy alopecia, like what you can see here. There is a patchy hair loss as well. Now there is also a mention of a pet dog at home, means domestic pets are there at home. Now, what is your right answer here? Yes, Surya is answering it right. The correct answer here, I would also agree with Surya that this is going to be Kirion. Now, what is Kirion? Now, this is one of a very commonly repeated MCQ when it comes to the NEET PG. Now, what is Kirion? Is it a bacterial infection or is it a fungal infection? Is it a viral infection? What is it? Any guess? Yes, very good. Osama is also answering it right. This is going to be Kirion. Now let us just note down what are the key pointers regarding Kirion. Now this disease called as Kirion is an example of tinea capitis. It is an example of tinea capitis. And which type of tinea capitis is this? Is it an inflammatory type or a non-inflammatory type? So this one is an example of inflammatory capitis. What do you mean by tinea capitis? There is a fungal infection of the scalp. So this is a type of dermatophytosis. Now what happens in Kirion is that this is going to be more common in children. Is going to be more common in children, and there is the child will always complain to you about a tender, boggy swelling of the scalp. So there is a painful swelling of the scalp. That is why I use the word tender. Tender boggy swelling of the scalp. Along with this tender boggy swelling, what other features can you get? Can you expect that there would be some regional lymphadenopathy? Of course, yes. So there can be associated regional lymphadenopathy. And most importantly, I showed you the image that the patient has gone into a patchy kind of alopecia. Can you see this image? So in this image, you can see that there is a patchy alopecia. What is the problem that is associated with this kind of patchy alopecia, which is seen in Kirion? Any guess? in the chat box. What is the problem with the kind of alopecia that you see in carry-on? So this will actually lead to scarring alopecia. Very important point when it comes to carry-on, that this is going to lead to scarring alopecia. I'm sure that during your preparation you must have learned about lot of causes of scarring alopecia. One of the important causes, that too in a child, is going to be carry-on. So tender boggy swelling, regional lymphadenopathy, scarring alopecia, and of course there is a history of a contact with domestic pets. Why? Because the fungus, the dermatophyte which causes this infection, is usually transmitted to humans from this domestic pets. So here the right answer is going to be carry-on. Now out of all these options, the other option was a furuncle. Now how many of you know what is a furuncle? Can you just let me know in the chat box, what is a furuncle? Is it fungal? Is it bacterial? Is it viral? Or is it something else? Who can answer? In the chat box, please. So this furuncle, this is actually a bacterial infection. And which bacteria can usually cause a furuncle? The most common bacteria which causes a furuncle is going to be Staph aureus. Staph aureus. The second example, yes, Osama, it is going to be bacterial. The second option was an epidermoid cyst. Now, what is an epidermoid cyst? This is the most common type of cyst that you can find in your body. And what is the last option? The last option is a folliculitis. All of us know what is itis. Itis means inflammation. So this is an example of an inflammation of a hair follicle. Now, this is also bacterial, which is caused due to Staph aureus again. Also caused due to Staph aureus. So in all these cases, in this MCQ, the appropriate answer should be carry-on. Now, if they ask you for the next NEET PG exam, a similar kind of an MCQ, but if they ask you what is your next step in management, or else what is the investigation of choice when it comes to carry-on, can you make any guess what should be your investigation of choice in this fungal infection which is called as tinea capitis or carry-on? I've given you all the clues in the MCQ itself. It's a fungal infection. So in this fungal infection, your investigation of choice should be potassium hydroxide test. Okay, potassium hydroxide test. So just like any other bacterial fungal infection, here also your investigation of choice is going to be potassium hydroxide test. And finally, they may ask you what is the treatment of carry-on. So we now have confirmed that carry-on is a fungal infection because we got KOH positive. And based on the clinical scenario also, we know that this is carry-on. Now, how do we treat? You must be knowing a lot of antifungal agents, isn't it? So are you going to apply something like an azole group of drugs like clotrimazole, ketoconazole, etc.? Or would you like to go for any systemic drugs? Systemic matlab, are you going to go for some tablets? Now, which is a preferred one? Is it terbinafine or is it griseofulvin? Would you like to make a guess? So remember, in the treatment of all the type of tinea capitis, the drug of choice is going to be griseofulvin. The drug of choice is going to be griseofulvin more than terbinafine. So I would say that the appropriate answer when it comes to the treatment part should be griseofulvin. Clear? So that is all about this first MCQ. So here we have whatever we have touched here in this MCQ was about the fungal infection, and that is tinea capitis carry-on. So now let's move to the next question. Now the question says that there is a child with a history of night blindness and presented to you with the following findings. What is the diagnosis? So night blindness, when I say about night blindness, is there any vitamin deficiency that comes to your mind? Vitamin A, B, C, D, E. Yeah, very good, Dr. Avinash. So this is hinting something to vitamin A deficiency. So in vitamin A deficiency, what is the skin over the elbow? Now, if I try to describe the lesion, I would rather I'm zooming it out for you. I would rather describe that there are multiple papular eruptions over the elbow. So what do you call for this multiple papular eruptions over the elbow in a child who may be having a vitamin A deficiency? Let's see the options. Is it a phrinoderma? Is it keratosis pilaris? Is it Darier's disease? Or is it follicular eczema? What's the right answer? So this one, remember, this is called as phrinoderma. Now, what is phrinoderma? The term phrinoderma itself means it means that there is a toad-like skin. Now, what is a toad? All of you know that a toad is a little frog. So when you see the skin of a child who has multiple papules over the elbow, and once you just try to palpate over the skin, you feel like you're palpating a little frog. That is why we call it as a toad-like skin. So very good, Osama, Avinash, all of you are answering it right. It is going to be phrinoderma. Now here, what happens in phrinoderma? So in phrinoderma, this is associated with multiple vitamin deficiencies. So the key point here is it can be associated with a lot of vitamin deficiency. It can be vitamin A, vitamin B, vitamin C, isn't it? Vitamin and all these vitamin deficiency, including the free fatty acid deficiency. Now, on the day of the exam, you can get a question which can be associated, just like in this question, it was associated with vitamin A. They can give you a clinical scenario which is associated with vitamin B, C, or whatever other vitamins. The only exception where you don't usually find a phrinoderma is this is not seen with vitamin D deficiency. It is not seen with vitamin D deficiency. That is one of the exception. And how will you treat any kind of a phrinoderma? Since it is going to be associated with multiple vitamin deficiency, the parents or the mother would be complaining that the child is not on a proper balanced diet. So you can better replace it with a multivitamin syrup or something. That would be the management of phrinoderma. That's the management of phrinoderma. Now let's go back to the same MCQ and see what are the other options that is given. The other option given is keratosis pilaris. Now what is keratosis pilaris? Keratosis pilaris is also compared to a chicken skin. Okay, so phrinoderma was frog or toad-like skin, whereas keratosis pilaris is compared to a chicken skin. Now, what is happening in a chicken skin? In chicken skin, once you palpate, you feel like it is like a chicken skin. It is usually seen in adults, which can be treated with retinoid creams and all. It is usually seen in adults. Whereas, what is Darier's disease? Darier's disease, in which section we would have learned about Darier's. So Darier's is a skin condition. It is an inherited kind of a vesicular bullous disease, which is usually due to autosomal dominant in inheritance, where a patient can present to you with dirty, warty, malodorous papules over the seborrheic sites. So that is another disease called as Darier's disease. The last one is follicular eczema. This answer would have been follicular eczema in case they did not mention in the question that there is a vitamin A deficiency. So since there is no if there was no mention, my answer would have been follicular eczema. But since there is a mention of vitamin A deficiency, so this is going to be more likely to be rhinoderma. Very good, Dr. Avinash. The Avinash is saying that ATP to A2. Yeah, because you must have learned that the problem here is in the calcium transport, isn't it? Calcium channels that is present, which is required for the proper functioning of the desmosomes. That is a defect that you can find in Darier's disease. Now, there is another disease which is also inherited, which you must have learned along with Darier's. What is the other disease? It's called as the Haley disease. The Haley disease. So excellent. So whenever you get any question from the nutritional deficiency, remember that all the vitamin deficiencies can be associated with a frog or a toad-like skin, which is called as phrinoderma. Called as phrinoderma. So shall we move to the next one? So with your permission, I'm just moving to the next one. Excellent, Avinash. Haley is also one of the other inherited diseases. I just wonder if you are able to answer this question, because since you said about Haley disease, now I told you that in Darius, this is some different topic. So in Darius, you can find the skin lesion over the seborrheic sites. Whereas my question is, where do you find the skin lesions when it comes to Haley disease? So in Haley disease, where do you find the skin lesions? Do you find them over the extensor surface? Do you find them over the flexural surface? Do you find them over the seborrheic sites? Or do you find them over the intertriginous areas or the body folds? Remember, the skin lesions are seen over the body folds when it comes to Haley disease. This is also mentioned as intertriginous areas. Is also mentioned as intertriginous areas. That is where you find a skin lesion or a bulla when it comes to Haley disease. Clear? Okay. So now let's move on to the next question. A 30-year-old patient presented with a flaccid bulla on her skin, which are easy to rupture. The biopsy revealed a suprabasal split. What is the most likely diagnosis? Now, in this MCQ, we are coming to a very important topic in dermatology, which is going to be vesiculobullous diseases. And you must have learned about many vesiculobullous disease. Just see the options: pemphigus vulgaris, pemphigus foliaceus, pemphigus vegetans, and there is one more option, that is erythema multiforme. And all these are very important vesiculobullous disease. Now, how do you approach them? The key points when it comes to a vesiculobullous disease is, try to identify the key pointers. There is a 30-year-old patient. 30-year means the patient can be a young patient or a middle-aged patient. The patient is having what type of a bulla? Is it flaccid or tense? The question says it is a flaccid bulla, which means it breaks very easily and which are easy to rupture. And the most important finding here is the biopsy reveals a suprabasal split. So this is another key point. So when you see that there is a suprabasal split, what is the layer in which there is a split happening here? Do you still remember what are the layers of the skin? Like the stratum corneum, lucidum, granulosum, spinosum, basal. Now, if there is a suprabasal split, suprabasal means above the basal layer. Now, what is the layer that comes above the basal layer? Yes, this is going to be the stratum spinosum. So, there is a split in the stratum spinosum where a patient is presenting to you with a flaccid bulla. Now, what is your answer? Surya, Avinash, all of you are getting it right. Excellent. So, here the right answer is going to be pemphigus vulgaris. So, in this MCQ, let us try to quickly revise what are the important pointers regarding various vesiculobullous disease. Like the most common vesiculobullous disease is called as a pemphigus vulgaris. Why do I say it is the most common? The name itself, vulgaris, means most common. In pemphigus vulgaris, you can see the lesion in the stratum spinosum. It is also mentioned as suprabasal bulla. Whereas in pemphigus foliaceus, what happens? Pemphigus foliaceus, the bulla is formed very superficially. Very superficially, matlab, what is the outermost layer of the skin? The corneum, isn't it? Just below the stratum corneum. So what is the layer? This is going to be in the stratum granulosum. So in the stratum granulosum, the MCQ may mention that the patient presents with a subcorneal bulla. The patient may present to you with a subcorneal bulla. That is why we call it as pemphigus foliaceus, stratum granulosum, and subcorneal bulla. And can you name one disease where you find tense bulla? Why? I'll give you the clue. If a bulla should be tense, which doesn't break very easily, It should be something that is present below the epidermis. I mean, not within the epidermis, somewhere below the epidermis. What is the name of that disease? That very important vesicular bullous disease. This is called as bullous pemphigoid. So remember, in bullous pemphigoid, we get a tense bulla because the bulla is formed not within the epidermis, it is formed below the epidermis. Hence, we call it as a subepidermal bulla. Hence, we call it as a subepidermal bulla. Okay, so all these three are going to be very, very important, repeatedly asked topics in NEET PG. And pemphigus vulgaris, foliaceous, bullous pemphigoid. Remember the area of split or the site of split, and also try to remember what is the defect in all these cases. So let us quickly note down what is the defect in pemphigus vulgaris. In pemphigus vulgaris, the defect is in desmoglein 3 more than desmoglein 1. That is a defect in pemphigus vulgaris. How about pemphigus foliaceus? In pemphigus foliaceus, the defect is in desmoglein 1. Now, what is the defect when it comes to bullous pemphigoid? When it comes to bullous pemphigoid, the defect is going to be BPAG2 more than BPAG1. So that is going to be the defect when it comes to bullous pemphigoid. So please remember all these points. It's a quite a volatile topic when it comes to dermatology. That is a vesicular-bullous disease. But you have to remember all these things. Even for the last INI-CET exam, they asked you about the investigation that is used in vesicular-bullous diseases in dermatology. So any idea what is the investigation that we use in all these vesicular-bullous diseases? Because this investigation is going to take us more closer to the diagnosis. Now, what is this investigation that we can do? Excellent. Surya is answering. It's called as the DIF, direct immunofluorescence. So in the last INI-CET exam, they gave you an image of a greenish fluorescence that is taken up by a patient of vesicular bullous disease. They asked you for what is this investigation done for. Okay, so this is going to be direct immunofluorescence. So that is all about all these vesicular bullous disease. And in the among all the options, the one that we did not discuss is about pemphigus vegetans, because vegetans is quite, it is a rarest type. Okay, this is the rarest type of pemphigus. In pemphigus vegetans, I would rather say that you need to remember about the typical type of a tongue finding that you can see in pemphigus vegetans. Any guess how does a tongue look like? I can give you some options as well. Does it look like a geographical tongue? Does it look like a magenta colored tongue? Does it look like some leukoplakia or something? Or does it look like a cerebriform tongue? Yes, so this is going to be called as cerebriform tongue. So in pemphigus vegetans, we can see a cerebriform tongue. This is one of the important points that you can remember about pemphigus vegetans. Now coming to the last one, that is erythema multiforme. Now, how does erythema multiforme look like? Can anyone volunteer or just let me know in the chat box, how is this erythema multiforme going to look like? Any guess? So this is also compared to a bullseye lesion or a iris lesion or a target lesion. Why do we call it as a bullseye? Because it looks like a bullseye. So there is a rim of erythema in the center, this one, in the center, we may have a vesicle or a papule or a macule. That is how a patient with erythema multiforme will present to you like. Okay? So whenever you find a bullseye kind of a lesion, target lesion or iris lesion, it is called as erythema multiforme. And in the central part, it can be either a macule, just a color change, or a papule, or it can be a vesicle. Fine. So that is about erythema multiforme. So now let's go to the next MCQ. What is the treatment of choice for a patient with paronychia of the index finger on the right hand as shown in the image? Now what they are asking you directly is what is a drug of choice or how do you treat a paronychia? For that we should first understand what is paronychia. So paronychia, what is the meaning of paronychia? Paronychia means there is a infection of the lateral nail fold. Infection of the lateral nail fold is called as paronychia. Just imagine that you had an injury somewhere over the tip of the finger. And after getting an injury over the tip of the finger, what if the next day you are waking up with a swollen lateral nail fold? So when you get a swollen lateral nail fold, this is what you call as a paronychia. Now, what is paronychia? Is it just an inflammation or is it an infection? It is actually in acute cases, this is usually going to be bacterial, and this is caused due to Staphylococcus aureus. Because due to Staph aureus. It's usually caused due to Staph aureus. So if you know the answer, keep paronychia, usually in acute cases, it is going to be bacterial, and the bacteria most commonly causing this infection is Staphylococcus. Now go back to the MCQ and see the options. Amoxiclav, metronidazole, amikacin, norfloxacin. What should be the right answer here? Any guess in the chat box, please? Yeah, so here the right answer should be amoxiclav. Excellent. So here the right answer should be amoxiclav because this is something what will respond very positively to Staphylococcus aureus infections, whereas metronidazole, amikacin, norfloxacin, these should not be used here, isn't it? So here this is somewhere you have to apply your knowledge कि paronychia क्या होता है, and then in paronychia what is a common causative organism, and based on the causative organism you will have to reach out a conclusion about which antibiotic should be chosen in the option. Okay? Excellent. Now let's go to the next one. A patient who is taking a multi-drug therapy presents with worsening of the existing skin lesions and nerve involvement. What will be your next best step of action? And they have given you some vague image as well. Now what is seen in the image is, now let us first see what is the MCQ like. There is someone who is taking a multi-drug therapy, which means multiple drugs are taken for some disease. Now how does the patient present it to you? The patient was having some skin lesions, now says that there is a worsening of the skin lesion. Now probably this lesion, all these lesions have become worsened, probably swollen, inflamed, etc. And also there is an involvement of the nerve. Now what is a disease that comes to your mind? The disease that should come to your mind here when you see such an MCQ is going to be leprosy. It is going to be leprosy. So in leprosy, what is the condition that we are talking about? So just moving to the next slide now. So what happens in leprosy is that there is something called as a lepra reaction. So remember how many types of lepra reaction? There are several types, out of which we will discuss about the most important types, that is lepra type 1 and lepra type 2 reaction. Now what happens in lepra 1 and lepra 2 reaction is that in lepra type 1 reaction, this is usually seen in all the types of borderline leprosy. Like how many borderline leprosy we may know? In that is borderline tuberculoid, borderline lepromatous. Whereas lepra type 2 reaction, this can be seen in all the lepromatous type of leprosies. How many lepromatous type of leprosy is there? Borderline lepromatous and lepromatous leprosy. What is happening in a lepra reaction or a lepra type 1 or type 2 reaction? In type 1, the existing skin lesions are inflamed. Along with inflammation of the existing skin lesion, there would also be involvement of the nerves. So here what happens, existing skin becomes inflamed and there is nerve involvement also. There is involvement of the nerves as well. Whereas what happens in type 2 lepra reaction? In type 2 lepra reaction, there is something called as erythema nodosum. So the patient here may present to you with fever along with erythema nodosum leprosum. What do you mean by erythema nodosum? There would be some subcutaneous nodules that is present, especially over the anterior part of the shin. So this is called as erythema nodosum. So how can the question be framed? A patient who is on multi-drug therapy complains to you with fever along with subcutaneous nodules. Think about lepra type 2 reaction. Whereas Whereas if the patient is complaining that a patient on multi-drug therapy is complaining of inflammation of the existing skin lesion. Now this is important, existing skin lesion. Then think about type 1 lepra reaction. Now let's go to the options and see what is the correct answer. Should we stop multi-drug therapy and start systemic steroids? Or continue multi-drug therapy and start systemic steroids? Or stop multi-drug therapy and give thalidomide and continue multi-drug therapy and start thalidomide? So what I will do is, I will always try to remember one very important sentence, that lepra reaction is not a drug reaction. That lepra reaction is not a drug reaction. If lepra reaction is not a drug reaction, what you will not do, you will not stop MDT. You will not stop MDT. So you have easily ruled out two of the options now. Now you will continue multi-drug therapy because it is not a drug reaction, correct? Now, will you start on steroids or will you start on thalidomide? What is the drug of choice in any kind of lepra reaction? So now you're coming to the right answer. The right answer here should be start on systemic steroids, because the steroids, they are going to be the drug of choice when it comes to lepra reaction. Now, in which type of lepra reaction can we actually use this drug called thalidomide? Is there any guess for this question? Remember, we can use this medication which is called as thalidomide. It can be used in lepra type 2 reaction. So this can be used in lepra type 2 reaction, that is thalidomide. But remember, drug of choice for type 1 as well as type 2 is always going to be systemic steroids like prednisolone. That is going to be the drug of choice. One more additional drug that you can remember is thalidomide. And where is thalidomide used? It is not used in type 1. It is used in type 2 lepra reaction. Is that clear? Okay. Thank you so much, Avinash. Fine. So now let's move next MCQ. A 30-year-old male patient presents to you with inflammatory alopecia. Which of the following variants of tinea capitis commonly result in this type of alopecia? See, when we do some previous year questions, what you should keep in your mind is what are the topics that is getting repeated. Now this is the second time we are talking about this topic, that is tinea capitis. First question was about chirion in a child with a patchy alopecia, remember? So now here again it is going to be repeated, which means that this is a repeatedly asked topic in the NEET PG. Now let's see which of the following variants will commonly result in this type of alopecia. Is it endothrix and favus? Is it ectothrix and endothrix? Favus and chirion? Chirion and endothrix? So for that, you should remember what are the types of inflammatory tinea capitis. So inflammatory tinea capitis. We have discussed today itself about what is one type of inflammatory tinea capitis. What was that? It was chirion. Remember scarring alopecia? So here, in which of the following options do you get a chirion? That is option C, isn't it? So now this is going to be the right answer here. Now what is favus as well as chirion? Both are examples of inflammatory type of tinea capitis. Now what do you mean by a endothrix and an ectothrix? So this endothrix and ectothrix, it basically means wherever you find the fungal spores, like if the fungus is present within the hair shaft, then you call it as endothrix. If the fungus is going to invade outside the hair shaft, we call it as ectothrix. Endo means inside, ecto means outside. That is a one thing that you can keep in mind. But here, since we talk about inflammatory alopecia, here the right answer should be chirion and favus. I just wanted to add one more point regarding favors. In case you get a question about favors, I'm pretty sure that the MCQ will always tell you that there is a child from Kashmir who is presenting to you with some kind of a scalp symptom. Now, why do I use this thing that a child is coming from Kashmir? Because this is one disease which is endemic. Endemic means that is localized to a certain location, right? So this is a disease that is endemic to Kashmir. It's called as favus. Again, just like another type of tinea capitis, this is also more common in children, and the child may present to you with a spoon or scutulum like crusting. So there are small crusts that you can see, or scaling or crust that you can see over the scalp, and this is compared to a small spoon or a scutulum. The scutulum like crusting can be seen when it comes to favus. Okay. Both favus and chirion, these are examples of inflammatory type of tinea capitis. Shall I move to the next one? Okay. So moving to the next one, the question says a patient presented to you with multiple anogenital warts. The biopsy of these lesions shows squamous atypia. Which of the following human papilloma virus is considered high risk? Now, in many times in the NEET PG exams, you can find that the question is about something else. But I mean, the clinical scenario is about something else. But they ultimately ask you a question which is not related to the question, to the clinical scenario. Now, why do I say like that? Is because here there is a patient with anogenital warts. What causes anogenital warts? Anogenital warts is caused due to human papilloma virus. Do you remember what are the subtypes which can cause anogenital warts? Subtypes of human papilloma virus which can cause anogenital warts. The subtypes are 6 and 11. However, what they are asking you is which of the following human papilloma virus is considered to be high risk? Is it HPV 2, 18, 6, 11? Any guess? This also is a repeatedly asked topic. Remember, HPV 18 is considered to be a high risk because in gynecology you must have learned that HPV 16 and 18, this can progress to some kind of a carcinoma. Now, what is a carcinoma? So 16 and 18, this can proceed to cervical cancer. That is the reason why this is considered to be a high risk type of a human papilloma virus. Now, one more thing that I would like to ask you here is, what do you call for anogenital warts? So in this image, you can find that there are some anogenital warts. What is the medical terminology for anogenital warts? They are usually called as condyloma acuminata. They're usually called as condyloma acuminata. So this is called as condyloma acuminata, which is caused due to HPV 6 and 11. So both 6 and 11 is considered to be a low risk subtype. The low risk subtype, it usually does not proceed into any kind of a malignancy. So which type of HPV proceeds to a malignancy? That is going to be 16 and 18, which is associated with cervical cancer. Before we move to any other topic, one of the very important question that can be asked in the NEET PG is regarding the treatment of genital warts. So what is the treatment of genital warts, or what is the treatment of condyloma acuminata? So they can be treated with imiquimod or podophyllins. They can be treated with imiquimod or podophyllins. So both imiquimod and podophyllins, what are they? They are going to be immunomodulators. So both are going to be an immunomodulator. Tell me if there is any role of antiviral agents when it comes to the management of condyloma acuminata. So please remember that there is no role of antiviral agents in the treatment of genital warts. So all the antiviral agents like acyclovir, ganciclovir, famciclovir, etc. So these does not have any role in the management of genital warts, and genital warts can be best treated with these kind of medications like imiquimod or podophyllins. They are actually immunomodulators. They are actually immunomodulators. But the question here is, imiquimod and podophyllins both are going to be teratogenic. So the problem here with imiquimod and podophyllins is that they are teratogenic. Now imagine a clinical scenario where you have a patient who has conceived and is now pregnant, and will you go for a management of condyloma acuminata in this patient? If yes, then why? Of course, we have to go for a management. The reason is the mother can transmit this infection to the baby, right? So to avoid this thing, what is the treatment of genital warts in pregnancy? So the treatment of genital warts in pregnancy is not going to be imiquimod and podophyllins. Reason is they are already teratogenic. So here the right answer would be cryotherapy. So here the right answer should be cryotherapy. So we use cryotherapy for the treatment of genital warts in pregnancy. So please note that these are the important points regarding condyloma acuminata. So moving further, the next question says that there is a farmer who presents to you with a swelling on the foot and multiple discharging sinus in the lower limb. Granules from the discharge were examined under the microscope. Which of the following is true regarding the condition? So there is a farmer, swelling of the foot. So if I don't say anything else, if you just say a farmer with a swollen foot, one of the most common diseases that comes to our mind should be a Madhura foot, correct? Which is also called as mycetoma. Also called as mycetoma. Now, see, all the characteristics of this disease called mycetoma can be seen in this MCQ. There is the first one is that is a farmer. The second thing is that there is a swelling of the foot and there is multiple discharging sinus. So all these three, isn't it? And there were from this sinus, what is getting discharged? There is granules. So the entire triad of, yes, Priya, you're right regarding pregnancy. It's cryotherapy. Excellent. So the triad of mycetoma is given in the MCQ. Swollen foot, discharging sinus, granules from the discharge. Now, based on these features, now let's see what is true. This condition is where both bacteria and fungus can be the causative, undergoes lymphatic spread, there is lymphocyte accumulation, involves only superficial tissue. What is the right answer here? So anybody in the chat box? Yeah, very good. A, that is both bacteria and fungus can be the causative. Now, why do we say that that is the right answer? Because whenever there is a bacteria which is causing Madhura foot, We call it as actinomycetoma. And whenever the causative is going to be a fungus, we can call it as eumycetoma. We call it as eumycetoma. And yes, excellent. Now, which is that fungal infection or a deep fungal infection which undergoes a lymphatic spread? So Priya is answering it right. So the lymphatic spread is usually due to sporotrichosis. So sporotrichosis, which is also called as the rose gardener's disease, you probably get a thorn prick with a rose plant and finally you develop sporotrichosis. That is where you have a lymphatic spread. Now here, since from the granules, when we send it for examination, if it turns out to be positive for bacteria, we call it as actinomycetoma and we treat it with antibiotics. Whereas if it turns out positive for a fungus, and then it is called as eumycetoma. Eu means true, and this can be treated with antifungals. So that is all about this MCQ about deep fungal infection. So please note down, deep fungal infection is something that you will have to learn properly before going for your NEET PG exam. Now let's see one more. A farmer presents to you with a cauliflower shaped mass on the foot, which developed after a minor injury. The microscopy shows copper penny bodies. What is the most likely diagnosis? What is the most likely diagnosis? So options are chromoblastomycosis, blastomycosis, sporotrichosis, phaeohyphomycosis. What is the right answer here? Whenever you find this thing, see again the same topic is being repeated. What is the same topic here? Again, we are talking about deep fungal infections. Previous one was Madura foot. Now this is something else. So don't forget to revise this topic. Now, the easiest way to identify is there is one key point here, copper penny bodies. Where do you find a copper penny bodies? Unfortunately, all my options are being marked as A. So Sridhar, I guess you are right because what you're saying here is chromoblastomycosis. Okay, very good. Excellent. So remember, deep fungal infections, very common in farmers. That is point number one. Second one, if you find a cauliflower-like exophytic lesion, and under the microscope, if you find copper penny bodies, there are many names for copper penny bodies. What are the other names? It is also called as medlar bodies. It is also called as muriform cells. It's also called as sclerotic bodies. So medlar bodies, muriform cells, sclerotic bodies, copper penny bodies, all these things are the names for copper penny bodies which can be seen in this deep fungal infection called as chromoblastomycosis. Now, why is this name chromoblastomycosis? So chromo means color. Okay. So this is a disease. So this is a disease which is caused due to a pigmented fungus. So this is a disease which is caused due to a pigmented fungus. That is why we call it as chromoblastomycosis. Fine. This is called as chromoblastomycosis. So what is the name of this pigmented fungus? This is called as Fonsesia pedrosi. So one of the most common organisms which can cause this deep fungal infection, it is called as Fonsesia pedrosi, which may cause cauliflower shaped mass on the foot, usually in a farmer. And if you do a histopathology, you can find copper penny bodies, medlar bodies, muriform cells, or sclerotic bodies. Fine. Okay. So now let's move to the next one. A patient presents with an anesthetic patch in the areas of the face as shown in the image below. Which of the following nerves is the most commonly involved in this condition? Now, I would say that the wordings of this MCQ is a bit tricky. Fine. Because what you find, whenever you find this key term which is called as an anesthetic patch, what is the diagnosis? Anesthetic patch means we will be thinking about leprosy. So in leprosy, there is an image which shows that what is the area that is involved. This leprosy, here the area that is involved is the face. So in face, this area is being involved here, that is a trigeminal area. So which means that this can be trigeminal nerve. But the question is, what is the nerve which is most commonly involved in this condition? So in leprosy, is it trigeminal or facial nerve which is more commonly involved? Yes. So Priya Garwal is answering correct. So the most commonly involved nerve in this condition is called as the facial nerve. Now just revise what are the some few things regarding the nerves. What is the most common peripheral nerve to be involved in leprosy? The most common peripheral nerve. Is it ulnar nerve? Is it median nerve or something else? So the most common peripheral nerve which is involved in leprosy is going to be the ulnar nerve. Okay. And the most, what is the most common, sorry. So yeah, we are talking about the most common nerves. Now, what is the most common nerve that is going to be involved overall? This is here, it is going to be facial nerve. The most common nerve or the cranial nerve that is involved. Most common cranial nerve that is involved is going to be the facial nerve. It is going to be the facial nerve. Fine. That is about the nerve involvement when it comes to leprosy. Now let's see the next question. So the next question says that there is a female patient with a body mass index of 30 kg per m square and it presents to you with a lesion over the neck as shown below. Which of the following condition is she most likely to be suffering from? Yeah, very good, Priya. Now here what you can find is what is the diagnosis based on the image. So based on this image here, the diagnosis is going to be acanthosis nigricans. And what is the most common association of acanthosis nigricans? The most common association is here mentioned in the MCQ itself, that the body mass index, the BMI of the patient is very high. Remember, the most common association is going to be obesity. It is going to be obesity. Along with obesity, there can be multiple other associations like diabetes, all types of metabolic syndromes. In female patients, there can be an association with PCOS. Rarely, there can be an association with malignancy, etc. Isn't it? So when there is all these associations, remember the most common association is obesity. And here, is it hypothyroidism, metabolic syndrome, Addison's disease, hyperparathyroidism? So here the right answer should be metabolic syndrome. Metabolic syndrome is going to be the most common cause of acanthosis nigricans based on all the options that is given below. And please remember, this one, rarely it is associated with malignancy as well. Is rarely it is associated with malignancy as well. That is about acanthosis nigricans. Now let's move to the next MCQ. Irregular pitting of the nails with subungual hyperkeratosis is seen in. So where do you find this irregular pitting of the nails? What do you mean by pitting? Pitting means there are some depressions over the nails. So yeah, lichen planus, psoriasis, atopic dermatitis, alopecia areata. I would say that there are two diseases here where you can find pitting of the nails. The two diseases where you can find pitting of the nails are psoriasis as well as alopecia areata. What is the difference in the pitting in both these cases? In psoriasis, you can find a irregular and deep pitting of the nails. Whereas, very good Priya, whereas in alopecia areata, what do you find? In alopecia areata, you can find a regular and shallow pitting of the nails. Clear? So whenever there is an irregular and deep, it is going to be associated with psoriasis. Exact opposite, regular and shallow is going to be associated with alopecia areata. And then where do you find subungual hyperkeratosis? Subungual hyperkeratosis is also seen in this condition called as psoriasis. Hence here the right answer should be psoriasis. In the chat box, Priya is saying correctly that you can remember it as poison. So let us quickly write down what are the nail findings in psoriasis. I completely agree with Priya. You can remember it as poison, where Poison. So what is poison? So P stands for pitting of the nails. And what is OI? I'll give you a clue that OI is the most specific nail finding in psoriasis. Now, what is OI? OI means oil drop sign. Oil drop sign. What is S? S is what we have in this MCQ. Subungual hyperkeratosis. Subungual hyperkeratosis. And what is O? O means there is a detachment of the nail, especially from the lateral part. It means onycholysis. And the last one, that is N. N stands for nail plate dystrophy. Okay, the entire morphology of the nail is lost and we call it as a nail plate dystrophy. So please try to remember the nail findings in psoriasis. Easy to remember if you remember this mnemonic, that is poison. That is poison. So clear? So with that, we go to the next MCQ. A 35-year-old woman presents to you with a hair loss for the past 3 months and she was tested positive for COVID-19 infection 8 months ago. What is the most likely diagnosis? So the options are tinea capitis, telogen effluvium, trichotillomania, female pattern androgenic alopecia. So what should be the right answer here? Yeah, excellent. So the right answer here is going to be telogen effluvium. Remember, tinea capitis we have already done twice. What was tinea capitis? That is a dermatophytic fungal infection of the scalp. Now here, this doesn't sound like a fungal infection, so that is already ruled out. Now, what is telogen effluvium? This telogen effluvium has many causes. So there is an increased shedding of telogen hair. That is what happens in telogen effluvium. One of the most common association is going to be stress. Stress is going to be the most common association. Now, why can somebody go into stress? I guess that all of you would agree कि exams के वजह से stress होता है, correct? So, of course, if you are finding that there is a lot of hair loss while you're preparing for your NEET PG exam, that is because of the stress that is being accumulated, and then this condition we can call it as telogen effluvium. Clear? Along with that, what are the other causes of stress? It can be because of an infection. It can be obviously COVID-19 infection. It can be tuberculosis. It can be typhoid. Any kind of an infection can lead to telogen effluvium. It can also due to pregnancy, because pregnancy is considered to be a stressful state. And is there anything that is considered to be a stressful state? It can be anemia, correct? So when the hemoglobin level comes down, then we call it as anemia. Again, can lead to telogen effluvium. And also sometimes surgery. So when a patient undergoes a surgery and is bedridden, and because of all this stress, the patient can have a complaint of increased hair loss. So remember, for your exam, if you get any question after COVID-19 hair loss, after tuberculosis hair loss, after pregnancy hair loss, after anemia like hemoglobin is less, the patient complains of hair loss, all these things is going to be a single answer. It's the telogen effluvium. That is going to be the telogen effluvium. And what is next one? That is trichotillomania. So trichotillomania, it means that mania, which means it has something to do with psychiatry, correct? So in trichotillomania, there is a impulse control disorder where the patient would be repeatedly pulling the hair. So when they repeatedly pull the hair, what happens? The patient may complain of a hair loss, a patchy kind of hair loss, that is called as trichotillomania. And the last one is the usual kind of hair loss that is commonly seen, androgenic alopecia, in males as well as in females. Fine. So here the right answer should be telogen effluvium. Moving to the next one. Yeah. A patient presented with the following allergic reaction. She was using a hair dye regularly. Which of the following would be the chemical that is responsible for the condition? You can see that after using a hair dye, probably because of the graying of the hair, the patient has developed an allergic reaction over the skin. You can see there is a lot of edema over the face, isn't it? Over the eyes cannot be opened. And there is some kind of a rash also behind the ears and over the scalp. Now, what is the diagnosis here? So here the diagnosis should be, yeah, very good. The correct answer here, the diagnosis should be allergic contact dermatitis. Okay, somebody who is going to develop an allergy because the skin gets in contact, with some allergen. This is called as allergic contact dermatitis. And what is the most common cause for allergic contact dermatitis, which is associated with a hair dye? So with hair dye, the right answer should be PPD. Just remember one point here, that with hair dye, there are two very common allergens. One is PPD, that is paraphenylene diamine, and there is one more which is called as PTBC, that is para tertiary butyl catechol. Para tertiary butyl catechol. That is going to be, these two are implicated in the allergic contact dermatitis due to hair dye. Now, PTBC, did we learn about something very similar? Like what in which condition where PTBP can cause a allergic contact dermatitis? Very good, Sridhar. This is considered to be the cause of allergic contact dermatitis because of bindi dermatitis. Yeah, the culprit is para-tertiary butyl phenol. When it comes to, yeah, Priya is also getting it correct. Sharon Shetty is also getting it correct. Excellent. So B for bindi, para-tertiary butyl phenol. So this is going to be para-tertiary butyl phenol. Now, just going back to the same MCQ, I would just like to add about one more thing. That is the last option. What is the last option? Sesquiterpene. Now, the sesquiterpene is also very important because the sesquiterpene is the culprit that is present in something which is the most common cause of allergic contact dermatitis. Can you make a guess? Like all of you are able to tell about bindi. What about the sesquiterpene? Sesquiterpene is the culprit which is present in a plant. What is the name of this plant? So this is called as congress weed, congress weed, or Parthenium hysterophorus. So remember, what is the most common cause of So remember, what is the most common cause of allergic contact dermatitis? The most common cause of allergic contact dermatitis is a plant which is called as congress weed or Parthenium hysterophorus, and the culprit that is present in this plant is called as sesquiterpene lactone. Sesquiterpene lactone. Priya says A, B, C, D. Excellent, Priya. What is A, B, C, D? Because this plant called Parthenium mystrophorus will cause allergic contact dermatitis through airborne contact dermatitis. Airborne contact dermatitis is A, B, C, D. Fine. That is all about this question. So now let's move to the next one. A 5-year-old child presents with the following lesions over the face. The child would be at the risk of developing which of the following? Now, what you see here is that you can see that there is a patient who is having a very large lesion, isn't it? What is the color of the lesion? Black in color. So there is a black colored mole that is present over the skin. Now, what is the diagnosis here? The diagnosis, it can be a giant congenital melanocytic nevus. So here the diagnosis is going to be a giant congenital melanocytic nevus. See, what is a congenital melanocytic nevus? This is a black mole which is present since birth. Now here we call it as a giant one because the size is going to be bigger. So whenever you get a very large mole which is present since birth, and what is the risk that is associated with this kind of a condition? Is it glaucoma? Is it melanoma? Is it basal cell carcinoma or squamous cell carcinoma? Very good, Sakshi. The right answer here is melanoma. Very good. Excellent. So please remember, this is a condition that is pre-malignant to malignant melanoma. So for your exam, remember two conditions which can be pre-malignant to malignant melanoma. The first condition is going to be a giant congenital melanocytic nevus. The second one is called as a dysplastic nevus. So remember that whenever you get an MCQ that a patient developed a mole recently and this mole is having multiple colors, the borders are irregular, etc. Always you have to evaluate it with a ABCDE algorithm. Why do we evaluate it for ABCD algorithm? To diagnose this condition called as malignant melanoma. So it's a highly metastatic tumor. Remember two conditions which are pre-malignant to malignant melanoma: giant congenital melanocytic nevus and a dysplastic nevus. Now tell me, which is a skin malignancy? Which is the skin malignancy which has maximum number of pre-malignant skin lesions? So which is a skin malignancy which has maximum number of pre-malignant skin lesions? Any guess? I'll give you the options: squamous cell carcinoma, basal cell carcinoma, malignant melanoma, and cutaneous T-cell lymphoma. Would you like to give any answer here? Yeah, remember, this is going to be squamous cell carcinoma. So if you get any image of a cutaneous horn, if you get a patient who is having oral lichen planus, if you get a patient who is having a chronic type of candidiasis over the oral mucosa, all these things are going to be pre-malignant to squamous cell carcinoma. Maximum number of pre-malignant skin lesions are associated with squamous cell carcinoma. But regarding malignant melanoma, just remember two: giant congenital melanocytic nevus and dysplastic nevus. Clear? And which is the carcinoma which has zero pre-malignant lesion? So let us add this one more sentence before we go to the next MCQ. Remember, basal cell carcinoma has zero pre-malignant lesion. So basal cell carcinoma has zero pre-malignant lesions. Clear? So with your permission, I'm just going to the next MCQ. A woman presented with acne, which was resistant to multiple cycles of antibiotics and unresponsive to oral isotretinoin. What would be the next step? Now, this is something more complicated because we know that acne, the wonder drug that we can use in acne is retinoid. It can be topical retinoid, it can be oral retinoids like isotretinoin, but this patient was unresponsive to oral isotretinoin and multiple cycles of antibiotics. It can be clindamycin, it can be oral doxycycline, oral minocycline was given, but the patient was resistant to all these things. Now, in this case, what will you do? Will you go for an antibiotic resistance testing? Will you test for hyperandrogenism or identify any dietary trigger factor or continue the same treatment? So, yes, Priya, the right answer here is going to be test for hyperandrogenism. So if you get a patient who is not responding for retinoids and who is not responding to antibiotics, there is no point of going for antibiotic resistance testing. Dietary trigger factor, Sharon, it means that there is something like that a patient of acne would be having a oily skin. Why oily skin? Because they may be having increased sebum production. Also, there is some associations with certain food, especially those with high glycemic index. If you go for more sugar in your diet, there is a chance that the acne can get exacerbated or worsened. Also, dietary products like eggs and all those poultry products and all, these can also worsen. So we usually give some general advice to the patients, right? So to avoid dietary products, also to avoid poultry products, to avoid high sugar products and all, so that we all these things can help in getting the acne better. Clear? So in such cases, what happens? So in this MCQ, there is no point of going behind a dietary trigger factor. So here, the best answer would be to test for hyperandrogenism. You take care of hyperandrogenism, then what happens? Once the entire hormones comes to normal, the acne also will get better. Will also get better. Now remember, if you get any MCQ based on acne, the drug of choice when it comes to uh, all types of acne except severe acne. Drug of choice in all acne except severe acne is going to be, what is the answer? This is going to be topical retinoids. Topical retinoids. Can somebody tell me what are the examples of topical retinoids? Topical retinoids, the examples are adapalene, tretinoin creams, etc. So in all types of acne, if they ask you what is a drug of choice or the first line agent that can be used, then think about topical retinoids. But when it comes to severe acne, the drug of choice in severe acne, the answer is not topical because those creams may not help you. Here you will have to go for something in tablet form. This is going to be oral isotretinoin. Oral isotretinoin, which is again a retinoid. So please remember this point when it comes to the treatment part of acne vulgaris. Very good, Sharon. What happened, Dr. AK? Is there anything that is confusing? If there is any confusion, just text me in the chat box. I'll be happy to answer and clear all your doubts. Fine. So now let's move to the next one. Yeah, clear. A woman presented with a painless genital ulcer with clear margins and bilateral lymphadenopathy, what would be the diagnosis? Syphilis, granuloma inguinal, chancroid, herpetic ulcer. So here we are talking about genital ulcer disease. Another very, very important topic for your NEET PG exam, genital ulcer disease. Now let's see how should we approach the MCQ of a genital ulcer disease. Here there is a patient who presented with a painless genital ulcer. Now I'll give you a trick, like whenever you find this term painful or painless genital ulcer, Then just note down painless genital ulcer. Please remember it as LSD. Painless. Matlab, painless means think about a drug. You take a drug, you will not get to know the pain. Think about something like that. Okay? So, what is the drug I'm talking about? LSD. So, what is L? L stands for LGV, lymphogranuloma venerum. S stands for syphilis. And D stands for donovanosis. So what is this donovanosis? Donovanosis was previously called as granuloma inguinale. So donovanosis was previously called as granuloma inguinale. Now remember, if you remember this one mnemonic, that is LSD, every time you get an MCQ about painful or a painless ulcer, then syphilis, granuloma inguinale, chancroid, herpetic ulcer, but the ulcer is painless. What are the two things that you can easily rule out? LSD is the one that is going to be painless, right? So LSD is painless. So syphilis is there. Granuloma inguinale is also painless. Chancroid can be ruled out. Herpetic ulcer can be ruled out because both these are examples of painful genital ulcer. Both these are examples of painful genital ulcer. Now, again, is it syphilis or is it granuloma inguinale? Now let's go back to the question. The ulcer has clear margin and has bilateral lymphadenopathy. Remember this name, donovanosis. This in donovanosis, remember there is no lymph node involvement. No venosus, no lymph node involvement. Please remember this thing because in granuloma inguinale, which is also called as donovanosis, there is no lymph node involvement and hence the correct answer here should be syphilis. Correct answer here should be syphilis. So I hope Sharan, Sakshi, Dr. AK, all of you are understanding this point. So whenever you get any MCQ regarding a genital ulcer disease, do the LSD first. Then you can rule out what is the painful genital ulcer and what is painless genital ulcer. And then after that, check for the other clue. So in this MCQ, the clue was bilateral lymphadenopathy. Donovanosis means donovanosis, no lymph node. So here the right answer is going to be syphilis. Clear? Moving to the next one. A HIV positive male with CD4 counts less than 50 presented to the OPD with multiple umbilicated lesions as shown in the image. See the image? So there is a very severe type of an eruption, probably because the patient is immunocompromised. CD4 counts are very less. So you are getting a very severe skin reaction, isn't it? Now here there is a key term which is called as umbilicated lesions. So in which kind of a disease did we learn that there are umbilicated papules? There is only one. What is the disease where you find umbilicated papules? Any guess in the chat box? Yeah. The umbilicated papules can be seen in a condition called as molluscum contagiosum. Excellent. Sakshi, Sharan, all of you are answering it right. It is going to be molluscum contagiosum. So in usually where do you find molluscum contagiosum? You can see molluscum in a child or we can see it as a sexually transmitted infection. But here it is an HIV positive patient and this patient has developed molluscum contagiosum. So in molluscum, what is important is what is the histopathological finding which is going to be diagnostic for molluscum contagiosum. The histopathological findings like what Sharan is saying is right. This is called as Henderson-Peterson body. Henderson-Peterson bodies can be seen. Now, along with this Henderson-Peterson body, there is one very important phenomenon which can be seen in this molluscum contagiosum. What is that important phenomenon called as? I'll give you a clue. It is some pseudo. So what is it called? It is called as pseudo-Koebner phenomenon. So pseudo-Koebner's phenomenon can also be seen in molluscum contagiosum. What do you mean by pseudo-Koebner? When one lesion becomes multiple lesion one after the other, because there is a auto inoculation of the virus, then it is called as a pseudo Koebner phenomenon. Okay, it's not Koebner, it's pseudo Koebner. Where do you find Koebners? So let us write down this one also. Where do you find a Koebner phenomenon? Koebner phenomenon is seen in three diseases, which you can remember it as LVP. So this is seen in LVP, that is lichen planus, vitiligo, and psoriasis. So what do you mean by a Koebner phenomenon? Koebner phenomenon means there is a appearance of new skin lesion at the site of trauma. Whereas if there are new skin lesions that is appearing because of the auto inoculation of the virus, then we call it as pseudo Koebner. So these are differences between Koebner and pseudo Koebner. Very good, Sakshi. Very good, Sharan. So all of you getting it right. Excellent. Now in this question, it was an HIV patient, and that is why we got a very severe type of molluscum contagiosum. And all the other options like histoplasmosis, cryptococcosis, Tallaromyces, all these things can also be seen in HIV patients, because these are going to be some of the examples of systemic mycosis which can be seen in immunocompromised patients. Clear? Now let's move to the next one. A 65-year-old diabetic female presented to the OPD with dyspnea, pain, and discomfort in the buttocks. The condition progressed and the black necrotic material was debrided from her entire skin. What would be the diagnosis? Can you make a guess what is the diagnosis? Pia says A. Sakshi also says necrotizing fasciitis. Excellent. So here the answer is necrotizing fasciitis. Sharon is also getting it right. See what is happening in necrotizing fasciitis. This is the kind of deepest skin infection. So it is a type of deepest skin infection because the epidermis, dermis, subcutaneous tissue, entire layers of the skin is going to be involved, along with the involvement of soft tissues, and because of this is considered to be the deepest kind of skin infection. The patient can present with multiple symptoms, like generally the patient may be looking unwell. There can be a high grade temperature. The patient can complain of very severe pain. The patient must be screaming because of pain. And what is the treatment here? The treatment here, we have to send the patient to the surgery department. For what? For immediate surgical debridement. We have to send the patient for a immediate surgical debridement, and along with that we will have to go for a broad spectrum antibiotics. So unlike how we usually write it as antibiotics, here I'm using the word broad spectrum antibiotics. Why broad spectrum? Because this necrotizing fasciitis is a condition which can be caused due to gram positive, gram negative, as well as anaerobic bacteria. So gram positive, gram negative, anaerobic bacteria. Hence, we have to go for a broad spectrum antibiotic, something like the piperacillin, tazobactam combinations and all. That is how you manage this condition called as necrotizing fasciitis. Cellulitis usually uh, presents to you in a different way, isn't it? Yeah, piptaz, meropenem, all these things. Correct, Sharan Sethi. Now, how do you get a patient of cellulitis? When do you suspect that a patient has got cellulitis? When a patient can present to you with fever with chills along with the inflamed skin, isn't it? The patient can come to the casualty with a high grade fever. The patient may be having some chills, but when you examine, especially some areas like the lower foot or leg, you can see that the skin has become very much inflamed. And in this inflamed skin, this would be having a vague border or a ill-defined border or a ill-defined border. So that is how you can find a patient of cellulitis. Whereas compartment syndrome again can be seen after a patient has got some fracture and all. And then pressure ulcer can be seen whenever there is at the sites of pressure. So here the best answer should be necrotizing fasciitis. Going to the next question. A patient presented with dermatitis, dementia, diarrhea. The condition occurs due to the deficiency of which of the following? Very, very simple, right? So we have been learning about nutritional deficiency since long. Now here in the question itself, they have given you the 3 Ds. Out of 4 Ds, 3 Ds are mentioned. Dermatitis, dementia, diarrhea. So what is this deficiency due to? Yeah, very good. It is due to vitamin B3. What is the name of this disease? Yes, Sharon, this is going to be due to niacin deficiency. And what is the name of this disease? It is called as the pellagra. So this can be a patient of pellagra who is presenting to you with diarrhea, dermatitis and dementia. And in this case, usually we can get the patient may be having a photosensitive rash somewhere around the neck. Now, what is this photosensitive rash around the neck region in a patient of pellagra called as? So in a patient of pellagra, the photosensitive rash around the neck region, we call it as, yeah, Sharan Priya, very good. This is called as Kazel's necklace. So this is called as Kazel's necklace. So this is about pellagra. It's called about pellagra. Let's move to the next one. Again, HIV. See, what I would like to emphasize is in the NEET PG, they have been testing you with skin lesions that is associated with HIV. So this is one area that you can try to focus on. Now let's see this question as well. A HIV positive patient presented with the following lesion. What could be the diagnosis? You can see that there is a mass within the oral mucosa which is kind of violaceous or purple in color. So is it a Kaposi sarcoma? Is it oral hairy leukoplakia? Is it melanoma or is it candidiasis? What is your right answer? Very good. So this can be Kaposi sarcoma. So Kaposi sarcoma, what is Kaposi sarcoma usually associated with? So is there any infection which is associated with Kaposi sarcoma? Just waiting for you to answer in the chat box. Excellent. It is associated with human herpes virus 8. So remember that in patients of HIV, one of the most common malignancies is going to be Kaposi sarcoma, which is also associated with human herpes virus 8. Whereas in the same patient who is having HIV can also have a finding within the tongue where the lateral part of the tongue may turn white in color. It's called as oral hairy leukoplakia. What is the commonest association of oral hairy leukoplakia? This is also another virus, also seen in HIV patient. But what is the name of the virus? It's called as the EBV. Now, what is EBV? Very good, Sakshi. This is going to be Epstein-Barr virus. So there is association with Epstein-Barr virus. A patient of HIV can also develop very severe type of a oral thrush or candidiasis. So that is also possible. Now tell me, which is the type of candidiasis which is considered to be a marker of HIV? Which type of candidiasis is considered to be marker? Come on. All of you are answering all this time in the chat box. I hope that some of you may be able to answer this question as well. Which type of candidiasis is considered to be a marker of HIV? It is going to be oropharyngeal candidiasis. Oropharyngeal candidiasis is a marker of HIV. The marker of HIV. Clear? So that is all about this question. Please make sure that you revise all the skin manifestations that you can find in HIV patients. Moving to the next one, a baby was brought to the OPD with a perioral rash with a delayed wound healing. What would be the most likely deficiency in this baby? Excellent, Priya. So Priya is answering zinc. So I'm also agreeing to her that this is going to be zinc. So Sakshi, Sharan, all of you are getting it right. Now what is happening here? There is a perioral rash. Okay, periorificial or a perioral rash which can be seen in association with zinc deficiency. It's called acrodermatitis enteropathica. So this is called as acrodermatitis enteropathica. In acrodermatitis enteropathica, there is a deficiency of zinc. This is a condition which is going to be autosomal recessive. And around what age can you see that a patient presents to you with acrodermatitis enteropathica? The patient may present to you during weaning periods. So when the mother is going to shift the baby from breast milk to cow's milk, that is a weaning period, then what happens? The zinc deficiency becomes much more obvious. And you can also try to remember there is a triad of symptoms which you can remember it as DAD. So D stands for diarrhea, A stands for alopecia, and D stands for dermatitis. D stands for dermatitis. So diarrhea, alopecia, dermatitis, this is a triad of symptoms which you can find in acrodermatitis enteropathica, which is due to zinc deficiency. Which is due to zinc deficiency. Fine. So now let's go to the next question. That a patient close differential. So the close differential, come on. Now here, what do you mean, Sharon? Like you mean some differential like chronic bullous disease? Just clarify what are you asking? Because what happens in acrodermatitis enteropathica is the patient would be developing this kind of dermatitis which is around the orifice, like the nasal orifice, oral orifice, over the anal orifice, etc. Fine. So these are the areas where you can find periorificial dermatitis. What happens around when the mother is going to exclusively breastfeed the baby, that is up to 6 months, absolutely no symptom. Now, when the mother is going to change the baby from breast milk to cow's milk, what happens? The zinc deficiency becomes obvious. The first symptom is always going to be this one, that is the diarrhea. So the baby will be coming with diarrhea, and this will be a pretty much surprising symptom that a small baby 9 months old, 10 months old will be coming to you with complaints of alopecia, loss of hair. And when you examine the skin, you can see that there is periorificial dermatitis. But if you ask about chronic bullous disease, in chronic bullous disease, what happens is that in this condition, which is called as chronic bullous disease of childhood, you are going to get bullous lesions, vesiculobullous lesions. In vesiculobullous lesions, that does not look similar because there you can find this vesiculobullous lesion arranged in a peculiar pattern. Now, what is this pattern compared to? It's compared to a string of pearls or cluster of jewel appearance. It is appeared like it appears like a string of pearls, something like this. So there would be a bulla which is appearing like a round, like a pearls, So string of pearls or cluster of jewel appearance can be seen. I hope it helps, Sharon. So with that, now let's go to the next question. A patient has come to the OPD with a history of multiple sexual partners and the gram staining has been deposited below. The treatment of choice. So someone who is having this kind of multiple sexual partners and maybe having some kind of a symptom. Now what they have shown is a gram staining. So this is, what is this? The treatment of choice. Before all of you, Kavi, Priya, all of you, before you answer what is a treatment, can you tell me what is a diagnosis here? I mean, you are right. Ceftriaxone is the right answer here. Before that, can we tell what is the diagnosis here? Seeing this image, what is a diagnosis that comes to your mind? Very good. That is going to be, so here the diagnosis is going to be gonorrhea. So what happens in gonorrhea? A patient can complain of a severe dysuria, isn't it? So here the patient may complain of severe dysuria. Along with that, the patient would be having a purulent discharge. Purulent discharge. So this is an example of a discharge disease. Earlier we had got an MCQ about genital ulcer. Now this is a question about a discharge disease. So whenever the patient is having severe dysuria along with a purulent discharge, you can think about gonorrhea. So in gonorrhea, when you do a gram staining, is it gram positive or gram negative? So in gonorrhea, you will be getting a gram negative organism. And what is so special? Does it look like a kidney kind shaped cells? Yeah, these are going to be diplococci. So these are going to be diplococci. So when you find these polymorphonuclear leukocytes, PMNL, so when you find that this within these polymorphonuclear leukocytes, if you find this diplococci, then you can think about Neisseria gonorrhoeae infection. And if the answer is going to be Neisseria gonorrhoeae, then the drug of choice for the management of gonorrhea is going to be ceftriaxone. Is going to be ceftriaxone. Whereas in non-gonococcal urethritis, what happens? The patient, instead of having severe dysuria, would be having a variant dysuria. And instead of a purulent discharge, the patient may be having a scanty kind of a discharge, isn't it? So these are the various differences between both the types of um, urethritis, both the types of urethritis. And please remember, the drug of choice here in when it comes to gonorrhea would be ceftriaxone. Ceftriaxone. So that is all about this discussion today. So what we have done today is that we have added all the MCQs from the previous years. So from this discussion, what I believe is that you will be understanding key deep fungal infections are very important. Fungal infections of the skin is important. In viral infections, the questions like condyloma acuminata, especially genital warts, has been asked several times. Nutritional deficiency, which is quite an easy topic, but questions are asked from nutritional deficiency as well. You also need to remember some of the vesiculobullous diseases like pemphigus group of diseases as well. Some common diseases like acne vulgaris is also asked, and obviously psoriasis is something that we cannot avoid. So all these are the topics which would be very, very important as far as dermatology is concerned. So is there any other topic that you would like me to discuss today among all these things? So if there is anything, you can just let me know. Otherwise, I wish you all the very best. Keep your preparations going strong. Try to practice more and more MCQs about all the topics that is commonly asked. We have already uploaded all those recorded videos in the app. And then try to practice MCQs, and please feel free to reach out whenever you feel that there is any difficulty in any of the subject, any of the topics in dermatology. Yeah, so thank you so much, all of you, for responding and making this session pretty much interactive. Yes, Priya, for similar topics are also being asked for the FMG exams as well. More or less similar. Some difficulty level may be changing, that's it. But please focus on all these common topics. So I think that is it. Thank you so much. And we'll come up with more sessions like this in the future as well. Thank you.